Hello all, and I am Dr. Vishwanath Satyanarayanan, Senior Medical Oncologist with Apollo Hospitals in Bangalore in India. And we welcome you all to the first of the ASCO endorsed webinar series conducted by the Creative Portal for Oncology Education and More. So it's a foundation, CPOEM Foundation. Today's webinar is on systemic therapy in operable HER2 positive breast cancer. And we have some renowned oncologists who will be giving talks tonight. And a few housekeeping instructions. Please ensure that the internet connectivity is good to have a seamless experience. By default, all attendees will be in mute and listen only mode. And attendees can also choose to ask questions by typing in the Q&A section. And this session will be recorded. So a few words about our CPOEM Foundation. It is a not-for-profit foundation. It was started in 2022. And we are mainly focusing on oncology education through webinars for fellows and practicing oncologists. So world-renowned oncologists have participated in the previously held webinars. We are also in the process of developing content for creating patient awareness about cancer. Dr. Santosh and myself are the trustees for this foundation, and we look forward to having many more sessions in the future. We also thank today's sponsors, the Zydus Pharmaceuticals, Roche, Viatris, and Intas for giving their educational grants for this particular webinar. And the agenda for today includes a talk by Dr. Sara Tolaney on treatment of early stage HER2 positive breast cancer, more towards personalization, followed by Dr. Sudeep Gupta's talk on how do I treat operable HER2 positive breast cancer in resource limited setting, followed by two case discussions, which will be presented by Dr. Swaroop and Pratusha, who are our early career oncologists. And we also have our session chairs, Dr. Sandra Spain, who is the Associate Dean for Research Development at the Georgetown University Medical Center and the Vice President of MedStar Genetic Medicine for MedStar Health in Washington, D.C. She is also a professor of medicine at the Georgetown University School of Medicine. She has received numerous awards and recognitions for her work, and she's published over 300 articles and is an internationally recognized leader in the field of breast cancer research and treatment. And she's also served as the president of ASCO from 2012 to 2013. And Dr. Shekhar Patil, who is also the other session chair, he's a senior medical oncologist from HCG Hospitals in Bangalore, India. So now, first of all, thank you, Dr. Sara, for accepting our invitation to be part of this webinar, which is co-branded by ASCO and CPOEM. And Dr. Sara Tolaney is a big name in breast cancer. In fact, Santosh and I had the opportunity to briefly meet Dr. Sara Tolaney at ASCO last year. She's the chief division of breast oncology, Susan Smith Center for Women's Cancer. Associate Director, Susan Smith Center for Women's Cancer, and she's a senior physician and associate professor of medicine at the Harvard Medical School. And she's got innumerable publications at the in high impact journals and also several awards. And in India, we keep talking about the APT trial, every now and then when we are teaching our fellows. And thank you, Dr. Sara. Over to you for your talk.
Thank you so much, first of all, for having me. It's a pleasure to be here with you. So thank you again for having me. Today, I'm really going to focus on how we've really tried to move towards personalizing therapy for our early HER2 positive breast cancer patients. We've seen that trastuzumab has really revolutionized outcomes for patients with early HER2 positive breast cancer, really decreasing rates of recurrence almost by half and having a tremendous impact. But yet the challenge is in the older studies with adding trastuzumab to chemotherapy, we've still seen with very long-term follow-up that about a quarter of patients still recur despite the addition of trastuzumab therapy, suggesting that for some patients, we do need to do more. On the flip side, for very small HER2 positive tumors, we've seen that an abbreviated chemotherapy regimen is associated with very few recurrences with now long-term follow-up, again, suggesting for others, we can get away with doing less. And so I think it suggests that we really do need to think about ways to tailor therapy to the individual patient so that we give the right amount of therapy to that patient to achieve the best possible outcomes while sparing them unnecessary toxicities. And so I think the way we've traditionally thought about it has been to de-escalate or maybe optimize therapy for patients who have lower risk disease. And we've tried to do this in a number of ways. We've tried by decreasing the amount or duration of therapy, but we've also tried to substitute treatments with less toxic approaches. On the flip side, for those patients who have higher risk disease, we have tried to add additional therapy, so add additional targeted agents, or replace some of our treatment with agents that are even more effective as we develop better treatments. And so we'll start off with potential ways to right-size therapy by decreasing the amount of treatment. And so we know, again, that trastuzumab does reduce risk of recurrence almost by half. But the interesting thing is that the pivotal studies really suggest that there's no interaction of the benefit of trastuzumab with tumor size or lymph node status, suggesting that this benefit of trastuzumab is really independent of these pathologic factors. However, in these large pivotal studies, Stage 1 HER2 positive patients were predominantly excluded from these trials. So in fact, there are very few patients with small node negative tumors. We do know, though, that stage 1 HER2 positive cancers are not so infrequent. It turns out that about a third of HER2 positive cancers that are diagnosed are stage 1 cancers. And so we do need to think about how to optimally treat this group of patients. And we had historic data to suggest that this group of stage 1 patients is at more than just an insignificant risk of recurrence. If you look at retrospective data from the British Columbia Tumor Registry that had patients that had stage 1 cancers, you can see that the HER2 positive group had a much higher risk of recurrence compared to the HER2 negative patients. And again, a risk that would suggest that systemic therapy may be warranted. And if you look even at the teeniest of the tiniest stage 1 cancers, so you start looking at T1AB node negative cancers that never got any systemic therapy, you can see that these patients still have significant risk of recurrence. This series to the left by MD Anderson suggested a 5-year relapse-free survival of about 77%. And in a slightly larger series from the NCCN looking at untreated T1AB node negative tumors, you see 5-year disease-free survival is about 83%. So again, even the small tumors do have some risk of recurrence. And I think the challenge with looking at these retrospective series is everyone's used a different definition of recurrence. And so, rates of recurrence do vary across different series, but in general suggests that T1A tumors may have 2 to 10% risk of recurrence, T1B 5 to 20%, and T1C 10 to 25%. So again, suggesting we may want to think about doing something. When our group started to think about this now many years ago, people were doing all sorts of things because we didn't have any standard treatment approach for what to do. Some people were giving the standard regimens that were used in larger tumors like ACTH or TCH. Some people took the opposite perspective and made up things and gave them Herceptin alone. And then others did different mixtures of things. And it really suggested that we need data in this setting. And so ideally, one would always want to conduct a randomized trial to address this patient population. But when we were thinking about this at the time, we really felt that this would be very challenging. We thought if we did a randomized study, having an arm that didn't have trastuzumab in it would be pretty impossible to accrue to because people already knew the significant benefit of having trastuzumab-based treatment. And both physicians and patients would probably feel uncomfortable with that. We also thought the standard regimens like ACTH or TCH at the time seemed too toxic. And while one could have thought about trastuzumab alone, we thought it probably wasn't optimal given that at the time we knew in the metastatic setting that it performed much better when chemotherapy was added. And I think a large driving challenge was that in a patient population where the event rate is lower than in a larger tumor population, if you give them treatment, your event rate is going to be very low. And so if you're going to compare two arms, you're going to need many thousands of patients to conduct a randomized trial. And so we just thought it probably wasn't going to be feasible to do. And so we decided to do a single arm study, which we called the APT study, where we took patients who had up to 3 centimeters of HER2 positive disease and didn't have nodal involvement, and in essence gave them the ACTH regimen without the upfront AC. So we just gave them the 12 weeks of paclitaxel trastuzumab, followed it by 9 months of trastuzumab monotherapy. And now we have 10 years worth of data And you can see that even with 10 years of follow-up, the event rate is very low, with just 6 distant events out of 406 patients. One challenge, though, I do think when looking at this data is when you look at 10-year invasive disease-free survival, it's 91%. And one could say, well, that's not that great. But you have to realize that this is a low-risk patient population. So the events that people are experiencing are not just breast cancer recurrence events. People can die from other causes, and it counts as an IDFS event. Someone can get a new contralateral primary breast cancer, not related to their original stage 1 HER2 positive cancer. That counts as an event. And so in a low-risk population, one lesson I certainly learned was that we do need to think about other endpoints, and recurrence-free interval to me makes a lot more sense because it's focused on recurrences that are related to that original cancer, including local events, distant events, and death from breast cancer. And here you can see 10-year RFI is about 96%. And given this lesson that we learned, we did get involved in trying to revise the STEEP criteria for endpoints in early stage breast cancer. And really in this STEEP 2.0 guidelines, we did recommend for low risk trials that people do consider this RFI endpoint so that you're not counting deaths from other cause, you're not counting new contralateral primaries, and you're not counting second primary malignancies that are, again, not related to that original cancer. So again, I think a lesson when thinking about these lower risk populations. And overall, this regimen was well tolerated. You still do see neuropathy, alopecia, fatigue, but rates of cardiac toxicity are very low with the non-anthracycline regimen. You see symptomatic congestive heart failure at just 0.5%. And so overall, we felt that TH was a reasonable regimen to consider for most patients with stage 1 disease. That being said, a single arm trial has a lot of limitations. You don't know if the T1A patients, for example, need therapy. Maybe they would have done very well without any systemic therapy. And there may be some patients who have very high risk disease that maybe we need to think about another strategy for. But despite being a single arm study, I think because there was such a low event rate, it had been adopted by many guidelines to be considered for the stage 1 population. But again, I do think a single arm study has limitations. And I think one question people raised is, would people have done better if they had gotten ACTH or TCH, which is hard to say given so few events that we saw in APT. But we did actually work with the FDA to do an analysis where we matched patients from APT with those patients from the pivotal registration trials, and then looked at outcomes. And you can see that, in fact, the APT regimen does just as well, if not numerically a little bit better than ACTH and TCH. So I really think it suggests that you don't need to give more therapy. So while we got away with getting a little bit less to lower risk patients, I think we wanted to do even better from a toxicity standpoint. And we thought, well, in the metastatic setting, TDM1 does better than TH with less toxicity. And it seemed to do just as well in Marianne compared to TH. And so we thought, well, what about substituting TH with TDM1 in this stage 1 population? But here again, the challenge is we couldn't really do a randomized trial for efficacy given so few events that would be seen. You need well over 3,000 patients in a randomized setting to even do a non-inferiority analysis between the two arms. And so we thought, why don't we repeat a similar design to APT and look at the efficacy of TDM1 in a single arm fashion in this population, but compare toxicity to TH. And so that's really the way ATTEMPT was designed, was sort of a unique design with co-primary endpoints to look at IDFS in the TDM1 arm and compare toxicities between the two arms. One challenge here is, how do you compare toxicities and what's the appropriate endpoint to do that? And we really wanted to think about toxicities that we thought affected patients' everyday lives. And so we came with what we called clinically relevant toxicities, which you can see really described here. And now we have about 5 years of follow-up on the study, and you can see that out of the 383 patients in the TDM1 arm, in fact, there were only 3 distant events at 5 years of follow-up, again, suggesting that this is a highly efficacious regimen. But when you compare toxicities, you can see that there were not numerically fewer toxicities with TDM1 compared to TH, which was not what we expected. We thought TDM1 would be associated with less toxicity. But you can see there are different toxicities. So obviously there's less neurotoxicity, which you would anticipate. But you have to realize we gave a year of TDM1 in this design, or you're only giving 12 weeks of chemo in the control arm. And so I think that is a challenge. And so we did see a lot of early discontinuation in this study in the TDM1 arm, where you can see that 20% of patients, in fact, didn't complete their year due to adverse events. And it wasn't just one adverse event that drove this early discontinuation. It was really a plethora of different things. Some people had some fatigue, some people had low platelets, some people had issues with liver enzymes. And so it was kind of all over the map for why people discontinued early. But I think another lesson that I learned is that maybe our clinically relevant toxicity endpoint didn't really capture all the issues with side effects that we really should be capturing. And maybe patient-reported outcomes really do need to be taken into account when comparing toxicity. You can see that quality of life was certainly worse, at least in the early part of treatment with TH relative to TDM1. Alopecia, certainly very important to patients, was obviously much better with TDM1 compared to TH. Women who are young and desiring to have future children, amenorrhea is an issue as concerns of fertility arise. And you can see that amenorrhea is much less frequent of an issue with TDM1 compared to TH. And so I think there are some advantages to TDM1 that shouldn't be discounted. And so while this study did not meet both co-primary endpoints, it didn't show less toxicity with TDM1 compared to TH. Just having treated a lot of patients with this and seeing how they do with quality of life in this study, you can see that I think there are patients who do tolerate TDM1 better. And so I think it is a reasonable alternative given the very good efficacy of this for patients who have concerns about things like neurotoxicity or alopecia, where maybe this is an appropriate alternative for them. And so I do discuss this with patients as another alternative for a stage 1 patient. That being said, I think a year of TDM1 is probably too much. And so we are conducting a study called Attempt 2.0, so another try at trying to right-size treatment. And here we're just giving 6 cycles of TDM1, so 18 weeks, following that with subcutaneous trastuzumab and comparing it to the TH regimen again. But we tried to learn from our lessons, and we did revise our clinically relevant toxicity endpoint to capture patient-reported outcomes as part of that toxicity determination, which again, I do think is important to do. We're also thinking about ways to get rid of chemotherapy entirely. And so the ADEPT trial is looking at the combination of subcutaneous trastuzumab and pertuzumab and endocrine therapy in stage 1 ER positive, HER2 positive patients. Really, in essence, doing this like an APT design with a single arm study, trying to look at what we think is a clinically meaningful endpoint. So I think in practice, what are we doing? I think we're mostly treating patients who have T1B and T1C tumors, either with TH or TDM1. But I will say sometimes there's a little bit of creep into the T1A patients, particularly if they have high risk features. So if they're like 4 millimeters or they've got LVI, I think those are things that do push us a bit to treat. But I think this is an area that's a bit unknown about how to figure out who needs systemic therapy. I think the other challenge we face is that, we have moved towards using preoperative treatment for most of our early stage HER2 positive patients, and yet these trials were designed as adjuvant trials. And the reason that is we really needed to confirm that patients had stage 1 disease to use a de-escalated approach. But we do miss out on the opportunity to understand response to treatment. And sometimes we're wrong. If we take someone to surgery and they have lymph node involvement, then we really missed out on giving them pre-op therapy, which I think is a problem. And it turns out our group wanted to understand if someone had a T1C tumor, what's the probability if you took them to upfront surgery that they would actually have nodal positivity? And it turns out up to 25% of people will have nodal positivity. And that, again, is a challenge because we do not want to be taking those patients to upfront surgery. We want those patients to get pre-op treatment. And so our group has really started doing uniformly axillary ultrasounds upfront in anyone who has a T1C clinical node negative tumor so that we can sense if there is potential nodal involvement, biopsy it, obviously, if there's anything concerning, and only take those patients to upfront surgery if they have a negative axilla by ultrasound, because we don't want to risk sending someone to surgery that's going to come back not stage 1. But I think this is an area that is going to evolve over time because it is still an open question about how to figure out the optimal a way to handle that. I think the other challenge is how much chemo do people need? And obviously, originally, we were very focused on using anthracyclines in HER2 positive disease, as many pivotal studies did incorporate anthracycline therapy. But then we saw data from BCIRG-006 suggesting that outcomes with TCH looked about the same as ACTH, even though they weren't technically, BCIRG wasn't technically powered to compare those two arms. But we've also seen that in a pre-op study that was powered to look at EFS, that the outcomes for non-anthracycline and anthracycline therapy look the same with dual HER2-directed therapy in a more modern era approach. This came from TRAIN2, which took patients to get the FEC taxane regimen with HP, or to get paclitaxel carboplatin with HP. It's a little different than certainly I would standardly treat people with. This is using 9 cycles of preoperative therapy. Mostly I'd be using 6 cycles of docetaxel carboplatin HP. But nonetheless, I think really a nice comparison of anthracycline and non-anthracycline therapy, and showing the same PCR rate between the two arms, and in essence, no difference in event-free survival. And importantly, also no difference in event-free survival, even in the highest risk patients with multiple node positivity. So I think between BCIRG-006 and TRAIN2, I think we can say that we probably don't need to use anthracyclines any longer in early stage HER2 positive disease. And we know anthracyclines are associated with more cardiac toxicity and numerically more events of leukemia. So really, I have stopped using anthracyclines in this patient population. So I think a nice way to try to, again, de-escalate therapy for patients. But there are patients who need more. And one way we've thought about trying to escalate therapy for higher risk disease has been to add treatment. And one therapy that we did add was pertuzumab, so another monoclonal antibody really trying to prevent HER2 dimerization. And we learned that it improved PCR rates from Neosphere and Trifina. And then we had data in the adjuvant setting from Affinity teaching us that adding pertuzumab to chemotherapy and trastuzumab did improve IDFS. At 4 years, the IDFS benefit was pretty modest, about a 2% delta. But we've now seen data with over 8 years of follow-up. And while there was no overall survival benefit in the ITT population, you do see that there continues to remain an IDFS delta with about 2.5% between the two arms. But where you see the difference is more significant is in the node positive patients, where you see there is about a 5% difference in IDFS and a small separation of the curves for overall survival in the node positive group, where no benefit at all is really seeing either for IDFS or OS in the node negative group. And I think one lesson here that I've certainly thought of is that we can't use early data in ER positive, HER2 positive patients to understand benefit of adding therapies, because we would have thought in Affinity that adding pertuzumab in the ER positive patients didn't add a benefit at that 4-year time point. But now with long follow-up, you do see that there is benefit in both ER positive and ER negative patients, but the restriction of benefit is really to node positive patients. So overall, who should we give pertuzumab to? I think anyone you're giving pre-op therapy to, usually that's over 2 centimeters or node positivity, those are patients I am giving dual HER2-directed therapy to. But I think a common question that gets asked is, well, what if you gave that dual HER2-directed therapy and they get a PCR? Do you need to continue that dual HER2-directed therapy out back? And actually a really nice paper that came out by our co-host, Dr. Swain, did show that perhaps we do need to be thinking about pertuzumab in the outback setting, because it did look at EFS by receipt of monotherapy with Herceptin the whole way through, dual HER2-directed therapy pre-op followed by just Herceptin, or dual HER2-directed therapy followed by dual HER2-directed therapy. And again, while this is not a randomized study, just numerically the events are fewer in the dual followed by dual therapy. And it is technically, we only have powered IDFS data from Affinity where people did get a year of therapy. And so I typically do give the year of treatment even to the PCR patients, but I think this does still an open question about, can a PCR patient actually de-escalate therapy, and how much treatment do they need And again, there are actually trials in discussion at the cooperative group level to try to address that. So finally, what about replacing therapy with even more effective treatment as we get better HER2-directed drugs? And I think Catherine did this beautifully, where they really said, if you take a high-risk patient who has residual disease and you escalate therapy by substituting trastuzumab with T-DM1, we can reduce events. And in fact, you see a 50% reduction in IDFS events by using T-DM1 in this residual disease population. We, however, did not reduce CNS events. Both arms had the same rate of CNS events, so not really preventing those as first site of recurrence. So while this data is outstanding and T-DM1 is clearly the standard in a residual disease patient, I still think there's a bit of room for improvement, because if you look at the node positive patients in Catherine, their IDFS is not quite as good as the ITT. We didn't improve CNS recurrences. And so I think there's still room for escalation for the right patient. And there are studies that are ongoing to try to address this, including Compass RD, looking to tucatinib, which maybe could help prevent those CNS events and to help reduce recurrences overall in combination with T-DM1. And then obviously we've seen TDXD's very impressive benefits in the metastatic setting, performing much better than T-DM1, really begging the question if it would do better than T-DM1 in the residual disease population. And so DESTINY-Breast05 is addressing this in a Catherine-like fashion, trying to substitute TDXD for T-DM1 here. And there are other studies ongoing in this residual disease population, including adding immunotherapy to T-DM1 for this group as well. And, I think there's even room to move some treatments to high-risk populations in the preoperative setting. And DESTINY-Breast11 is doing this, trying to substitute the AC-THP regimen with TDXD, either in full, replacing that whole regimen with TDXD, or replacing half the regimen. And so this trial is currently accruing. So I think, just to conclude, where should we be heading as we now have all these very impressive HER2-directed agents, and we've learned we can try to change outcomes by understanding response in the pre-op therapy and adapting in the adjuvant setting, but could we use earlier response to adjust? And I think the FAIRGAIN study has done this nicely, saying maybe we can get away without chemo in those patients who have great PET response early on. And so can we give dual HER2-directed therapy, look at their PET response? If they are responding well, then just use HER2-directed therapy without chemo to get them to surgery and then give it continued out back. And how does that compare to standard chemo? And what they've shown us so far is that this strategy does help enrich for PCR, but what we're waiting on is EFS data to see if it really holds up that you can use a non-chemotherapy regimen in a good PET responder and achieve similar outcomes. So we need to learn if this is an optimal strategy or not. And then could we use PCR as a way to tailor? We've used residual disease to tailor, but we are not standardly using PCR to tailor. And we know that the PCR patients generally do well. With dual HER2-directed therapy, you see that rates of recurrence are overall probably in the 8 to 10% range. And we've now seen some pilot data looking at this, including Daphne, which had just done THP pre-op and achieved about a 60% PCR rate. And these patients who got PCR just got HP out back. So they were, in essence, not getting that carboplatin part of their therapy and getting shorter duration treatment. And so this is being validated now in the Compass HER PCR study, which is enrolling, which is doing this, giving THP pre-op. If you get a PCR, you just complete your adjuvant HP. But I think this strategy is important, but I do wonder if it's going to be an appropriate strategy for all comers, because we know not all PCRs are the same. If you have very high-risk baseline disease, you have like a T3, T4 tumor, we've seen that those patients who have big tumors or nodal positivity upfront and achieve PCR do have higher risk of recurrence than someone who has a smaller tumor and achieved PCR. So I think PCR doesn't erase all your risk factors, and we may need to think about tailoring differently in those very high-risk patients in the future. And we may get smarter. We may develop biomarkers to help us tailor things like ctDNA. If we could figure out who had ctDNA after surgery, we do know that those patients have higher risk of recurrence, and maybe that will help us figure out who needs to escalate. And then finally, what about true biomarkers, looking at the biology of the tumor? There's this assay HER2-DX, which I think is very promising because it helps you not just predict PCR, but also helps you predict prognosis with 2 different scores. And there is validation data suggesting it can really pick out differences in IDFS using this gene expression analysis. And they now have very nice data suggesting it separates PCR very nicely across now multiple trials. We had looked at this assay in our stage 1 trials, including APT and ATTEMPT. And while there are very few events in these studies, you can see separation where HER2-DX was able to predict which patients recurred compared to those who didn't. And so maybe this is going to be a path forward for us to tailor even beyond looking at clinical pathologic risk, but really understanding biology of tumors, which I think is really critical for us to do when we start to tailor further. So I think where this leaves us is currently for my small tumors, I am taking them to upfront surgery. If they have a T1C tumor, I'm getting an X-ray ultrasound to confirm that there is no nodal involvement, at least gross nodal involvement, and then I can give them TH or TDM1. Whereas if they have a larger tumor or have nodal positivity, I'm using TCHP pre-op and then using HP out back for the PCR patients and TDM1 out back for the residual disease patients. And I think this really just shows you we've come a long way over the last decade in HER2 positive disease. We've learned how to tailor therapy based on response to therapy. We've learned how to give less therapy for smaller tumors, but I think we still can refine better as we're getting better and better HER2 directed drugs. We're going to need to figure out who needs which treatment and how much of that treatment. And I do think we need to move towards understanding biology, not just using clinical pathologic information. And so hopefully that will be our path forward. But thank you so much. I really appreciate your attention.
For that wonderful talk, and it was so comprehensive, and there's so much happening in the HER2 space. Thank you so much. And now we move on to the next talk by Dr. Sudeep Gupta on how I treat operable HER2 positive breast cancer in resource limited setting. And I request Dr. Sandra Sween to introduce Dr. Sudeep Gupta.
Okay, thank you. There were 3 questions. Did you want Dr. Tolaney to answer them? I think she touched on them in her talk, but maybe just briefly. One of them, Sara, are there any situations in which you consider anthracyclines?
That's an excellent question. And I feel like I trained on the East Coast and I learned to just give anthracyclines in HER2 positive disease. But I've really changed my ways. And I will say there isn't anyone. I used to think maybe for inflammatory breast cancer that was HER2 positive, I would use anthracyclines. But actually our group has data now looking at non-anthracycline therapy that shows PCR rates that are very similar to what we've seen with anthracycline treatment, even in inflammatory disease. So even taking the highest risk group, we're doing just as well without the anthracycline. So there isn't a particular patient that I have really used anthracyclines in.
That's great. I think you answered the next 2 questions with your schema at the end. And then the last question, who will you recommend to get the HER2-DX testing?
Yeah, well, I think this assay is really interesting because it is really separating out who's going to achieve a PCR and who's not. And well, it's not something we're routinely doing at this time. It's not, for example, commercially available in the US. I do think one way we may turn towards it, again, as we get more data, is let's say Compass PCR is positive and we want to use THP in our patients. The problem is if you predict wrong and you give THP and they have residual disease, you're going to end up escalating that patient out back and giving them a heck of a lot more therapy because you predicted wrong that they're not going to get away with less. So in my mind, we need to know upfront who can get away with less so that we can stick with giving them less and not making them end up with a lot more therapy. And so I think in those patients with, for example, stage 2-3 disease, understanding who has high probability of achieving PCR with dual HER2 directed therapy and who has an excellent prognosis will help us give less therapy and give more to the people who have, low rates of PCR with that treatment. I think in stage 1, this is going to become a little complicated because, again, the event rate is so low. It's going to be a select group. And so I think we're going to need to figure out how to use it. My hope is maybe it'll help us figure out who doesn't need treatment with smaller stage 1 cancers, which is our current struggle, but more work needed.
No, that's great. It was a great talk and really exciting work that you and your group have done. So thank you very much. So now I'd like to introduce Dr. Sudeep Gupta. He's a professor in the Department of Medical Oncology and the director of the Center for Treatment, Research, and Education in Cancer at the Tata Memorial Center in Mumbai, India. And he trained at the All India Hospital of Medical Sciences in New Delhi and has more than 300 publications. And I'm very much looking forward to hearing his talk next. So, Dr. Gupta.
Thank you very much, Dr. Swain, for your kind introduction. And can I please be given the opportunity to share my screen? So thank you very much for the opportunity to make this presentation today. I would like to thank the organizers, Dr. Swain, for the kind introduction. The remit that has been given to me in the next 20 minutes is to talk about the management of HER2 positive non-metastatic breast cancer, particularly in resource limited settings. To begin, we know that breast cancer is now the most incident cancer among Indian women, having overtaken cervix cancer in this regard several years ago. So it is a very important disease. Furthermore, you can see this data from several hospital-based cancer registries in India that patients present with more advanced stage disease compared with the data that is presented here from the SEER database in the US and patients in several other more affluent Western countries. On the plus side, India has the cost of anti-cancer medicines that is several times lower than that in many other countries, including the US. And that, of course, is because of the robust generic pharmaceutical industry that we have in this country. This is an analysis on a cohort of patients registered in a single year at Tata Memorial Center, and this is from 2008, but it is still instructive. So I will share this data. About 17% of the patients had HER2 positive breast cancer by IHC 3+, and a further 8.1% had IHC 2+, of whom about 40% were HER2 amplified. So about 20% of our patients were HER2 positive in that calendar year. And you can see in the data to your right that HER2 positivity did not differ by the age group, unlike TNBC and ER positive disease, which respectively declined and increased with advancing age. So, of course, everybody knows, but let me reiterate that treatments may be effective, but they are useless if patients cannot access them. This is the famous and the then somewhat controversial editorial by Dr. Hortobagi in the New England Journal of Medicine just after the presentation and publication of the adjuvant trastuzumab data, where he called trastuzumab a revolutionary treatment. And of course, in hindsight, he was absolutely spot on. So coming back to the same data from the same cohort of 2008 patients, and this was a few years after the publication and presentation of the adjuvant results, you can see that of the 441 patients who were eligible to receive HER2 targeted therapy in that calendar year, only 38, which is about 8.5%, ended up receiving trastuzumab, and half of them on a clinical trial. We reanalyzed this data on our cohort of 2016 patients, and in this year, the access to trastuzumab had improved to 60% for a number of reasons that I will share with you shortly. And this access has further improved in the past few years. So how did we improve access to HER2 targeted treatment? By using social partnerships and philanthropic support for patients, use of shorter durations of adjuvant treatment, and of course, because of the availability of lower cost biosimilars of trastuzumab. We analyzed the survival outcomes of a cohort of patients who were treated with 12 weeks of neoadjuvant or adjuvant trastuzumab on a patient support program. We published this data recently with a relatively long follow-up, but this belongs to about 10 years ago, 11 years ago. And you will note here that 57% of these patients had clinical T3 or T4 tumors, and close to 90% of these patients had node-positive disease. So this was a group of patients with really advanced, although non-metastatic disease. And they received 12 weeks of trastuzumab, mostly in the neoadjuvant setting. And we reported the survival outcomes with a follow-up of 72 months. The 5-year disease-free survival is 66%, and the 5-year overall survival was 76%. And we concluded that 12 weeks of trastuzumab is at least better than not giving trastuzumab at all in patients who lack access to the full 1 year of trastuzumab. The question that has been asked, and also in 6 randomized trials, is the following: is shorter duration trastuzumab an acceptable alternative to 1 year of trastuzumab? A couple of years ago, we conducted and reported an individual patient data meta-analysis of the 6 randomized trials. We used extracted individual time to event data from the published survival curves of these trials using a method that had been recently published by statisticians from UK. We used the Stata command IPDFC and the software WebPlot digitizer to extract individual time to events and then synthesize them together. This is an example of the extracted survival times from one of those randomized trials, the one published by Dr. Pivot, the French trial. On your left are the extracted survival times, and on your right are the reconstructed individual patient data survival curves from this trial using the extracted data. For all the included trials in our analysis, the estimated hazard ratios for disease-free survival and overall survival are on the left, and the reported ones are on the right. And you will note that they closely match each other, as did the number of events that were estimated by us and reported by the authors. So these are the main results of our study. The hazard ratio for shorter durations versus 1 year of trastuzumab for disease-free survival was 1.14. And this, the right bound of this 95% confidence interval was to the left of the pre-specified non-inferiority margin. And the overall survival hazard ratio was 1.17. These are the reconstructed individual patient data survival curves from all the 6 trials combined, and these are in approximately 11,000 patients. And you will see that for disease-free survival, there was a 1.7% absolute difference in the 5-year disease-free survival, with a 1.1% absolute difference in overall survival. We did conclude that shorter durations of adjuvant trastuzumab were non-inferior to its 1-year administration and resulted in lower rates of cardiac toxic deaths. Breaking the results down by stage, you can see that the hazard ratios are trend towards non-inferiority in patients with lower stage disease. For stage 1, 1.17, for stage 3, 1.43. And this data was available from only 2 of those 6 published trials. With respect to nodal status, you can again see that the hazard ratios were more towards non-inferiority in patients with clinically node or with node negative disease compared with node positive disease. And the same trend for ER positive compared with ER negative disease. For ER negative, the hazard ratio was 1.1. For ER negative, it was 1.23. And as might be expected, cardiac toxicities were lower in the group that received shorter durations of trastuzumab with congestive heart failure being clearly less common among these patients. So in patients with low-risk HER2 positive disease, especially those with ER positive tumors, the duration of adjuvant trastuzumab could be de-escalated without a large loss of efficacy in patients with resource constraints and among those with concerns about cardiac toxicity. In collaboration with colleagues from the Postgraduate Institute in Chandigarh, we also evaluated the cost effectiveness of adjuvant trastuzumab in the Indian scenario using the assumptions of gross domestic product per capita from India and also the costs of the available brands of trastuzumab. On the x-axis here is the cost of 440 milligrams of trastuzumab, and on the y-axis is the probability of 1 year of trastuzumab being cost effective given the current state of India's GDP per capita. And you can see that as the cost declines, there is a ever higher probability of 1 year of trastuzumab being cost effective. Our overall conclusions from this analysis were that 1 year of trastuzumab was not cost effective at the current price. However, shorter durations, especially 9 weeks, is cost effective and should be included in clinical guidelines and reimbursement policies. A price reduction of up to 15 to 35% increases the probability that 1 year of trastuzumab will become cost effective in the Indian setting. This is another database from several institutions, and these differ from our own results because these are private sector institutions which treat the more affluent category of patients, and this was reported a couple of years ago, although the cohort of patients is relatively older from between 2008 and 2014. About 20% of patients had HER2 positive disease, and because trastuzumab was quite expensive about 10 years ago, only about 46% of this cohort of patients also received trastuzumab. And you can see that patients with HER2 positive disease had a 5-year disease-free survival of about 81%, which was significantly lower compared with the outcome for ER positive patients. Among HER2 positive patients, those with node positive disease had significantly inferior outcome compared with those with node negative disease, and this of course would be expected. These are results that set the benchmark for further studies from India. In patients with T1N0 disease and those who had HER2 positive disease, the disease-free survival was 90% and the overall survival was 100%, but these were only 68 patients. So this is the last bit of data that I will share, and this is not yet published. This has just been analyzed literally like a couple of days ago. So the analysis is not complete, but I thought I will share a couple of interesting observations. These are patients registered at our hospital between 2014 and 2018, 1,004 patients, and all of them have received neoadjuvant treatment for HER2 positive breast cancer. Relatively advanced stage disease, again, 65.2% of patients had stage 3 breast cancer. 70% of these patients received any trastuzumab either in the neoadjuvant or in the post-operative or both settings. Maintenance trastuzumab after neoadjuvant treatment was received in only 36% of patients. 22.5% of patients achieved a pathological complete response in the primary tumor and the axillary lymph nodes. This is lower than what is reported, contributed, in my opinion, significantly by the fact that these were patients with advanced stage disease. I want you to see this slide very carefully. To your left are the patients who have achieved a pathological complete response, and the two survival curves therein are patients who received or did not receive trastuzumab at any point of time. And you can see that so long as they achieved pathological complete response, there wasn't a difference in the survival outcomes. To your right are patients who did not achieve a pathological complete response. And here, patients who received trastuzumab at any point of time fared significantly better than those who never received any trastuzumab in the curative setting. And some of you will recall that this data is very reminiscent of the pembrolizumab data from Keynote 522, where patients who achieved a PCR with or without pembrolizumab achieved an excellent outcome and similar to each other, whereas those who did not achieve a PCR had significantly better outcomes with pembrolizumab compared with without. So, as was shown by Dr. Tolaney, within the patients who achieved a pathological complete response after adjusting for multiple covariates, the baseline clinical tumor size was a significant prognosticator, and patients who had larger tumors had worse outcomes compared with those who had smaller tumors at baseline despite achieving a pathological complete response. So all pathological responses are not created equal, and this must be taken into account when we are tailoring our treatment. So let me summarize. Cancers, including breast cancers, continue to present in relatively advanced stages in the Indian patients. And over and above any drug, I think downstaging is likely to be the most effective measure to improve outcomes. Access to HER2 targeted therapy is improving, but is not universal among Indian patients. And we must take measures to further increase access, at least to trastuzumab among our patients. Short course trastuzumab may be a reasonable alternative in patients with low risk disease and when access to HER2 targeted therapies are limited. Biosimilars of trastuzumab and TDM1 and generic versions of lepatinib have improved access to these drugs because of lowered costs. Pertuzumab is expensive and is accessible to only a small proportion of Indian patients. And as was shown by Dr. Tolaney, and as we all know, it adds something to the outcome, but not a big difference with or without this drug. Trastuzumab deruxtecan, neratinib, tucatinib, and other newer HER2 targeted drugs are not yet marketed in India and are not accessible to the overwhelming majority of our patients. Anthracycline-based regimens continue to be widely used in India, and in my opinion, are an important component of treatment of HER2 positive disease, especially when access to HER2 targeted therapy is limited. Thank you very much for your attention.
Thank you so much. That was really a great talk and really useful to see the meta-analysis that you did.
Dr. Swain, I think there are a couple of more questions in the chat box. So
there were a couple of questions for Dr. Tolaney, and I think that pretty much we're going to discuss this with the cases too. Is there a role for de-escalating trastuzumab to 6 months? I think that we just heard a great talk on that and what the role would be. And then the last one is really a hard question, and I'll ask Dr. Tolaney to comment on this. Is PCR a good surrogate endpoint for overall survival, especially in early breast cancer?
I think that's a great question, and we don't have a study powered to actually answer that very well. You know, I think PCR does seem to be a reasonable surrogate for EFS, you know, on a broad level. But I think my worry is, you know, it actually also speaks to Dr. Gupta's data, because he also saw that amongst the PCR patients that there are individual characteristics that do influence risk. And I think this is where we're struggling a little bit, is that, you know, again, a PCR is not a PCR. It is based on individual characteristics. And so I think we don't have great data to answer that question. And I think we're going to need to understand biology even beyond PCR to understand outcomes for patients.
No, I think that's really a great answer. And it may be some of these immune profiles that really are going to be helpful to determine, at least in HER2 positive disease and triple negative disease. There was a recent report in the Journal of Clinical Oncology trying to answer this question. And you probably all know that the FDA with Patty Cortazar did an analysis too and didn't really find that PCR was a good surrogate. Well, this recent analysis by the German group also did not find that the PCR was a good surrogate endpoint for survival. So I think that, for the individual patient, it's a good thing, but we still don't know which of these patients actually are going to have a recurrence, because we know some will. So I think it's an excellent question that we don't really have the answer to. So thank you.
Thank you, Dr. Swain. And thank you, Dr. Sudeep Gupta, for taking us through the real world scenario in India, and also the significant bioeconomical aspects which we have in India. So now the next session will be Meet the Experts. I request all our experts, Dr. Sandra Swain, Dr. Shekhar Patil, Dr. Sara Tolaney, and Dr. Sudeep Gupta to participate in this case-based discussion. And we have two early career oncologists, very dynamic, and they just started their career as oncologists. So to start, it will be Dr. Swaroop of the first set of cases, and he will be discussing the cases mainly with the de-escalation strategies as the scenario. Over to you, Dr. Swaroop. And Dr. Swaroop is a medical oncologist at Sagar Hospitals and Chinmaya Mission Hospitals in Bangalore. Over to you, Dr. Swaroop.
For the introduction, Dr. Vishwanath. Good evening, everyone. And good morning. So I'll be speaking about a few clinical real-world examples wherein we have done de-escalation of treatment among patients with HER2 positive disease. So the first patient is a 72-year-old lady with hypertension, ischemic heart disease, underwent recent coronary stenting, and the current ejection fraction of 45%. She had underwent upfront modified radical mastectomy and was stage T1B N0, ER negative and HER2 positive disease. So we treated her with 12 weekly paclitaxel doses and then a year of adjuvant trastuzumab exposure with total anthracycline avoidance. And she had good tolerance, and there was no worsening of ejection fraction, and she remains disease-free at 3 years after completion of treatment. So I got a couple of questions to our esteemed panelist, Dr. Sara Tolaney here. So the first question would be, regarding the APT trial, 2/3 of the patients were hormone receptor positive. So how safe is this protocol for patients with hormone receptor negative disease? And the second question is that the trial mandated an ejection fraction of 50% or more. But in the real world setting, we do come across patients with much lesser ejection fraction. So how do we go ahead with them in clinical practice? Do we frequently monitor ejection fraction, or how's it in your practice? Over to you, Dr. Sara Tolaney.
These are excellent questions. And you're right that in APT, about 2/3 of patients were hormone receptor positive, and actually not dissimilar also in ATTEMPT. It was a little bit lower, but very similar. And so, it's actually not that different, though, for most adjuvant HER2 trials are usually about 60% hormone receptor positive if you look across most of the studies to date. We've actually will be presenting some data at ESMO Breast, actually putting together the APT and ATTEMPT data, and actually looked at HER2-DX across both of those, as well as predictions. But I will say it didn't seem to matter if you're a hormone receptor positive or negative. Again, even when you put the data sets together, outcomes are very good in this population when you're treated. And so I think, again, it's adequate for ER negative patients and ER positive patients. We do know from retrospective studies that ER negative patients do have slightly higher risks of recurrence compared to hormone receptor positive patients. We also know time to event is a little different in ER positive compared to negative. But overall, I think reasonable for both patient populations in this lower risk population. With regards to your cardiac toxicity question, also a very important question. So, in a clinical trial, yes, we did mandate this EF of 50%. And as you point out, in the real world, not everyone has an EF above 50%. And so how safe would it be? we actually did an analysis where we looked at cardiac risk factors and rates of cardiac toxicity in both APT and ATTEMPT that have separately been published. And what we found in APT was that if you had a baseline low ejection fraction, so less between 50 and 55%, and you had 2 additional cardiac risk factors, those were the people who ended up having these drops in EF. So, we counted both an asymptomatic drop in EF, so more than a 50% delta, or you fall below 50, or you had symptomatic congestive heart failure. And those are the people who are at highest risk. So we do worry about those people. So the baseline EF is borderline, and they've got additional cardiac risk factors, just like your patient here with age and needing a stent. And that's a risky patient to be giving HER2-directed therapy to. Even without an anthracycline, we've certainly shown that these are the people who tend to drop. So these are patients at our institution that we would get into cardio-oncology, make sure they're optimized, ACE, beta blocker. We do monitor them very carefully. We're usually doing echoes every 3 months in these patients for a year. But it did beg the opposite question, is if you had someone with very good cardiac function, without cardiac risk factors, do you really need to monitor them that often? Especially if rate of congestive heart failure is only 0.5% with a non-anthracycline regimen. And I will say this is hotly debated in the cardio-oncology world, where I think many of us feel you probably don't need to be monitoring them, at least if you looked at our analysis from APT, that these patients really rarely do develop any trouble if, again, they don't have a low baseline EF and they don't have 2 additional cardiac risk factors. But we don't have prospective data showing that. And so I will say our standard is still to continue to monitor throughout the year of treatment. And in fact, I will say our cardio-oncologists actually also ask, and we're not routinely doing this truthfully, but that we check an echo 1 year post completion of HER2-directed therapy as well, which I think makes sense maybe for someone who got anthracycline and trastuzumab, but we haven't done that in this kind of a population.
Can I just make one brief comment? Is that we actually did a prospective study called Safe Heart in patients who had an ejection fraction between 40 and 50%. And of the 30 patients, 27 of them did fine. And they got HER2-directed therapy, various things, either trastuzumab, pertuzumab, or TDM1. So I think you definitely can treat if you have the cardiac status optimized, as Dr. Tolaney said, with the beta blockers and ACE inhibitors, and have them followed by cardiology. So I don't have any hesitation of treating them with HER2 targeted therapy. And there was a question in the chat about someone who has an injection fraction of less than 30%. I actually had a patient that was 35% that treated her for years with HER2 targeted therapy. So I think you can do it. You just have to be very carefully doing it and following with cardiology.
Thanks a lot, Dr. Swain. And
So
Dr.
if you
Tolaney.
allow me to just add a
Yes,
point there. So I think those are excellent points. Just a number on ejection fraction is not a contraindication to HER2 targeted therapy. But let me say that one should also try to evaluate the non-breast cancer mortality, the predicted non-breast cancer mortality of that person in the next 5 years or in the next 10 years. This is, if there are competing causes of mortality that are likely to overwhelm any benefit that you will derive out of adjuvant treatment, one has to consider that while treating these patients. And in the patient that you have described, the tumor size, the nodal status, I suppose it was negative.
yes.
All of that, and plus the patient's symptomatic status, what NYHA class she is in, all of that is important over and above, and the comorbidities are also important above and beyond the 45% ejection fraction.
Thanks a lot, sir. So I'll proceed to the next patient. She's a 45-year-old fit lady with no comorbidities. However, she had poor societal support. She had 2 young children as dependents. Clinically T3N1 ER negative HER2 positive grade 3 disease. She was treated with neoadjuvant 4 cycles of AC, followed by 4 cycles of docetaxel. We could not afford trastuzumab in this patient yet. After surgery, she was found to be YPT1N0 completed radiation. By the time we were able to arrange for some funds, and we gave her 6 months of trastuzumab exposure. So seeking a question regarding our 6 months of trastuzumab data with the Persephone trial, I request the views of Dr. Sudeep Gupta here. So in this specific population of premenopausal ladies with ER negative grade 3 HER2 positive node positive disease, what would be the long-term outlook for short course trastuzumab?
So,
yes, sir.
So, my views are already known, and I showed the data that there may be some loss of efficacy, but not by much. If we are able to give them 6 months of trastuzumab. And if we don't have the funds and if there is no access to more than 6 months of treatment, then anyways, you can't give it. In such a patient with node positive high grade tumor, which is ER negative, and I believe the tumor size was 3 cm T2, I would personally prefer to give them 1 year of trastuzumab. But if that is not available, then 6 months of trastuzumab, in my opinion, is a very eminently suitable alternative.
Thank
Maybe
you,
we would like to hear the views of our colleagues from the US, because we already know what we do.
Well, I think that you presented a great argument and data for doing the shorter course. So I think that, we have not accepted that in the US, and we do have a standard 1 year, based on the data that's out there. I am involved in the Early Breast Cancer Trialists Collaborative Group, and we are trying to gather actually all the individual data from all of the trials that have length of treatment. And hopefully we will get those in the next year or two and can have a definitive analysis of that. I think probably you'll see a benefit to 1 year, as you showed, in the higher risk patients with more positive nodes, et cetera, and maybe a small benefit in even the node negative and the 1 to 3 positive nodes. But as with all of our analysis that we do in the EBC TCG, it'll be a proportional reduction. You just have to look at the risk benefits. So I would agree with what you have said, that if you can't get it and you can only get, for example, 3 months, that's better than nothing. And it's probably not going to be as good as 1 year, but it certainly is better than not treating at all.
Thank you. So I would like to
actually, I just want to add to that 1 year is slightly better than shorter durations in patients with relatively higher risk disease. But if you look at the data that has been published by all the trials and also our meta-analysis, the loss of efficacy is not huge. It is not like a difference in disease-free survival of 8%. It is like 1.5% or 2% or 2.5%. So of course, 2.5% is something, and the hazard ratio will be what it will be. But one has to not feel too guilty about not being able to give 1 year if one cannot give it.
No, I think you're absolutely right. And I think that, was my point about the analysis that we're doing, that people will be able to judge, okay, if it's only a 1% difference, then, it's not worth doing, or if it's 8%, it is, like we do with everything else.
Okay, so I'll proceed to the next question here to Dr. Shekhar Patil. In a hypothetical patient with clinical T2 and 0 ER positive, HER2 positive disease, should we place more emphasis on chemo de-escalation or on reducing the duration of trastuzumab?
I would feel more in a hormone receptor positive patient, the role of chemotherapy itself will become questionable in such an early disease. Yes. So definitely chemo de-escalation will give more importance. And trastuzumab duration also can, because it falls in the low risk group, both can be tried. But if you ask only one which can be de-escalated, I will give more importance of de-escalation on the chemo part rather than the trastuzumab part.
Thank you, sir. I'll proceed to the next patient. We have a 68-year-old lady with multiple comorbidities.
Can I, with your permission, elicit the views of our colleagues from the US? So, ER positive, HER2 positive might mean a 12% or a 15% ER positivity and might mean like an 80% or a 90% ER positivity. Would you consider treating them a little bit differently from each other, or both are considered as ER positive, HER2 positive?
Yeah, I guess just to start off, I think with HER2 positive disease, I think there's been such a stress placed on the importance of giving these patients, irrespective of ER status, currently chemotherapy with HER2 directed therapy. And so I think that that's still our current paradigm. You know, I agree that I would want to de-escalate the chemotherapy much more so than the trastuzumab, simply because of toxicity. But obviously cost is a different issue. And I do think there's a lot of cost benefit to also de-escalating trastuzumab. And one could argue, can you do both? Because if you could understand the biology, or you could understand in combination response to therapy, maybe someone who has a T2N0 tumor who gets THP and has a PCR, can they stop? Do they even need additional therapy? And I think there are some studies currently being planned that if you have low enough baseline risk and you achieve PCR, maybe we can get away with less therapy. And in this case, they just get adjuvant endocrine therapy out back. So I think we have a long way to go. Obviously, our group's also looking entirely at replacing chemotherapy with just endocrine therapy and HP. And so I think for those patients, there we did want them to have ER greater than 10%, to your point, that we wanted them to be at least endocrine driven enough to benefit from endocrine therapy if we're going to get rid of chemotherapy. So I think we have a lot to understand, but I personally think we're not going to get there until we can individualize therapy based on biology.
Right.
Thank you. Thank you. So the next patient had multiple comorbidities, including hypothyroidism, diabetic neuropathy, recent coronary bypass graft, with clinical T4A-N1 ER negative HER2 positive disease, 68-year-old lady with ECOG2. So we treated her with a chemo-free approach using neoadjuvant TDM1 and pertuzumab, achieved a pathological complete response during surgery, completed radiation, and continued TDM1 for a year. So she was treated without any taxane, no platinum, no anthracycline, with manageable toxicity profile and good quality of life. Remains disease-free at 2 years of completion of treatment. So the rationale was the Christine phase 3 trial regarding chemotherapy avoidance, which tested TDM1 pertuzumab versus DCHP, with a higher risk of low co-regional progression before surgery, but lesser adverse event-related treatment discontinuation. So I request Dr. Sandra Swain's opinion regarding the Christine trial results and the special implications on patients with comorbidities. Over to you, Dr. Swain.
Well, I think you made exactly the right choice for this patient. I mean, it's a difficult patient with a lot of comorbidities. And as you state here, the main difference in Christine was this local regional progression before surgery, whereas the invasive DFS was the same for, I think it was about 3 years for both groups. So I think that you absolutely made the right choice. You have much lower toxicity with a TDM1 and pertuzumab without the chemotherapy.
Thank you.
Since this patient had morbid obesity, you used 3.6 milligrams per kilogram of TDM1. You gave her what, 380 milligrams of TDM1, something like that?
No, sir. We capped the dose at about, I don't exactly remember, but we did not go to the full dose.
You know, from my own experience, of course, TDM1 has a different toxicity profile compared with chemotherapy, but is not nearly as non-toxic as everyone thinks it is.
Well, I think Dr. Tolaney showed that with the ADEMPT study, and you do see patients that do have nausea with it. And sorry, didn't mean to interrupt you.
Oh, no. I was going to say the same thing, that I think you're exactly right, that a year of TDM1 is hard, right? We saw 30% of people in Catherine also didn't complete a year. Just as Sandy was saying, it is a lot harder. There's some neuropathy that starts to happen. There's that fatigue, nausea, LFTs, thrombocytopenia. So it's not so easy. But, you know, in this study, I do think it was interesting that it's the people of low HER2 and HER2 heterogeneity that are the people who get the local regional progression. And so I will say in my heart, I kind of wish we could repeat Christine and throw those people out and just use the highly HER2 driven people, because then we could get away with a non-chemo, like TDM1 still chemo, but it's a lot easier than TCHP. We know that from a quality of life perspective. So I feel like we've done a disservice by not trying to develop this further in the right patient, which is too bad.
And it may be different when we have trastuzumab deruxtecan. It may not make such a difference with the heterogeneity.
I think that's an excellent point.
Yeah. So I'll proceed to the next patient. She's a 75-year-old lady with ulcerative colitis, schizophrenia, VSD, and a poor ejection fraction with the locally advanced breast cancer, ER negative, HER2 positive, the specific kind of patients which clinical trials always exclude. So in the quest for safety, which neoadjuvant regimen would be used? So among TCHP, THP, and TDM1 alone, we decided to give neoadjuvant TDM1. Following which, during surgery, we found out she is YPT1, completed RT, and continued to receive TDM1 for a year with dose modifications, of course. She was having a fair tolerance, and she's fine at 2 years of completion of treatment. So the rationale for this was the PREDICTS HER2 randomized phase 2 trial, which tested THP versus TDM1 with pathological complete response rates of about 45 to 47%, not as good as in the other trials, but still fairly okay for patients such as this. So in a patient such as the one described here, how do we make the difficult choice between THP, TCHP, TDM1, and TDM with pertuzumab? So requesting Dr. Sara Tolaney for her views here.
I will say in the US, outside of a clinical trial, we're not using TDM1 in the preoperative setting. Again, I think it's not that it's wrong, it's just that we haven't developed a study that's shown we know which patients can get away with this and do just as well as TCHP. I think, Christine, while the IDFS was the same, that was only from the point of surgery on. That was throwing out the local regional progressions when they did that analysis. And so we don't have a study powered that's actually shown us that we know how to pick the right patients where they can do better than TCHP. So while I love the regimen, I do worry about it. Our group had also done a study with TDM1 pertuzumab pre-op and shown that there was no PCRs in the patients who had HER2 heterogeneity. And so that's the problem, is we need to figure out which patients are homogeneously HER2 positive and strongly HER2 positive. And then I think this is an excellent therapy, but I've not been doing it outside of a clinical trial at this point, and I don't think in the US insurance would uniformly cover it, even if I wanted to, because I do think there are patients I'd want to do it in, like you did. I think it was a very nice choice for her, but it's just not our standard currently.
So how's your experience with people with ulcerative colitis with regards to pertuzumab and the diarrhea which it entails?
And it's the docetaxel actually that also is really working me in the ulcerative colitis. So the docetaxel and pertuzumab is going to be a problem from a GI perspective in this patient. Sometimes I get away with the paclitaxel in some patients, but it depends how well controlled her ulcerative colitis is and if there's anything else that could be done to optimize control. I do actually have a patient with UC that did struggle even with standard paclitaxel pertuzumab. And so it is tough. And I agree that TDM1 is much nicer in this particular case, but I do try to optimize the bowels here too.
Thanks a lot. So I hand over to Dr. Vishwanath for the next presentation.
Thank you, Dr. Swaroop, for this interesting case scenarios. And now we have Dr. Pratyusha, who is a medical oncologist with Apollo Hospitals, and she will be presenting a couple of cases for the experts' insight, and her theme will be on escalation. Over to you, Dr. Pratyusha.
So my first case would be, she's a 57-year-old postmenopausal woman with no known comorbidities. She was evaluated for a right breast lump in the month of September 2022. Subsequently, a bilateral mammogram was done, which was suggestive of a BIRATS 4C, and clinical staging was CT2N0M0, which is stage 2A. A true-cut biopsy was suggestive of invasive ductal carcinoma of grade 2 with a ER of 5, PR of 5, HER2 3+, and Ki67 of 20%. Subsequently, a PET-CT was done, which showed an increase in the FDG uptake in the right breast at 3 o'clock position of size 2 into 2.1 into 2.5 centimeters with no nodal uptake and no distal metastasis. So my first question would be to Dr. Sara Tolaney. Would you prefer an upfront surgery followed by adjuvant therapy if the tumor size was T1B or T1C?
So if the tumor was a T1B, I would recommend going to upfront surgery again, assuming the axilla had been assessed with a negative axillary ultrasound. In a T1C tumor, I think if they're a small T1C, I do tend to take them to upfront surgery again, assuming negative axilla. Once they start getting kind of between 1.5 and 2 centimeters, I do get a bit anxious because, again, we've started to show that about 25% of these people come back node positive, and then I've missed the window for pre-op. And so that 1.8 centimeter tumor, truthfully, I'm giving them THP pre-op. I sort of hedge and say, you know, they might be node positive, I don't know, and I'd rather give them the upfront THP therapy. So I think it depends how big they are. And again, I do like to make sure nodal status has been assessed.
An extension to the same question, in a case like this, wherein it is a borderline 2 centimeter, where it is just 2 to 2.1 centimeter, would you go ahead with neoadjuvant therapy or an adjuvant or a upfront surgery?
I would want to give this patient neoadjuvant therapy with a 2 centimeter tumor.
Okay, thank you. The next question would be directed to Dr. Sudeep Gupta, sir. Which neoadjuvant regimen would you be using if an upfront surgery is not planned in this particular case? Would it be a 4-drug or a 3-drug or a 2-drug regimen?
So I will tell you what we do in the large majority of such patients. If the axillary lymph nodes are negative, including by an ultrasound, most such patients will undergo upfront surgery in our hospital. And if we do use neoadjuvant chemotherapy, our default regimen is AC times 4, followed by paclitaxel and trastuzumab, followed by surgery.
Okay. Thank you, sir. The next question I would like to direct to Dr. Sudeep Gupta, sir. Is it worthwhile using pertuzumab in the neoadjuvant setting? What is your experience in using neoadjuvant pertuzumab?
I'm not a great fan of pertuzumab, especially in the neoadjuvant setting. You can increase the PCR, but as we have discussed, increasing the PCR is not what is important. It is actually the impact on long-term outcomes. So I sometimes use pertuzumab, especially in patients with very advanced disease, particularly if they can, only if they can afford that drug. But for the most part, our neoadjuvant regimen is anthracycline, taxane, and trastuzumab, followed by surgery. And then if they have residual disease, and if it is accessible, then they receive TDM1 in the post-op setting.
The same question I would like to direct to Dr. Sara Tolaney and Dr. Sandra Swain as well. Like, what would you do in the US? Like, is it worthwhile using pertuzumab in the neoadjuvant setting?
Cindy, I don't know if you'd like to start.
No, I think, we feel it definitely is, because you do, and Dr. Tolaney showed this, that pass CR rates are higher, almost 70%, 63% in the Trifina study. And as was shown in the Affinity trial, though it's an adjuvant trial, you do see a benefit in those patients that have the higher risk tumors. So we usually are using the TCHP in the neoadjuvant setting in these patients who have the higher risk tumors, not the lower risk that Dr. Tolaney showed in the APT trial. So I do think it's a benefit. And the analysis that Dr. Tolaney showed that we did, even though it wasn't randomized, did suggest a benefit of doing it both using pertuzumab, both pre-operatively and post-operatively.
I would agree with Sandy. I was just going to echo that. I think the challenge I face is that in the pre-op setting, I don't always know nodal status. And, in Affinity, the benefit is really only in the node positives, right? In terms of long-term outcomes. Certainly there is the extra benefit of improving PCR, which could decrease nodal surgery, which has its own potential benefits. But I think the issue is it really changing survival? And you don't always know that up front. And so I will say I tend to hedge and just give people the pertuzumab, but I realize I am over-treating some patients potentially who are not going to get long-term benefit from it if they truly are node negative.
And if you actually look at other data, like the NSABP data, about a third of the patients, even though you think they may clinically be node negative or even by ultrasound. A third of them or so will actually have positive nodes. So, I mean, I agree with you and do the same. I really tend to overtreat by using pertuzumab. Now we have the luxury of being able to do that in the US, and I understand the issue, when there's cost is an issue of not using it, does make sense.
As this patient, we started her on neoadjuvant therapy with the TCHP regimen according to the TRAIN-2 and TRIFINA trials. She received her last chemo on 21st of January. And after finishing her chemo, she underwent a right breast lumpectomy with a sentinel lymph node biopsy and local oncoplasty. A post-op histopathology report showed a tumor measuring of size 1.8 into 0.9 into 0.5 centimeters. That is a YPT1C with no nodes. So she did not achieve a complete pathological response. In view of no complete pathological response, the patient has been started on adjuvant trastuzumab emtansine based on Catherine trial. Now, with a short follow-up in the Catherine data, is it worthwhile using TDM1 right away or spare it for later option in the metastatic setting? I would like to direct this question to Dr. Sara Tolaney.
I think what we saw in Catherine is you're reducing risk of recurrence by 50%. It is really dramatically different. And so while, yes, we only have the 3-year follow-up, which I'm not quite sure why it hasn't been updated yet, I still do think that that is really an important benefit. And honestly, you don't want your patient to get metastatic disease. That's a life-threatening problem, right? So I will do anything to help prevent that from happening. And given the striking benefit here, I would give TDM1.
And I couldn't agree more. I think that, a lot of young oncologists might use this hypothesis here is, spare it for later. We don't want to spare it for later. We want to cure them now in the early stage. So I think that that's not a good way to look at it.
The next question would like to Dr. Shekhar Patil, sir. So what do you think is the role of only adjuvant trastuzumab despite no complete pathological response?
So basically, if somebody is able to afford based on the Catherine trial and very strong data in reducing the recurrences, I would feel TDM1 will be the way to go about. But if the drug is not available or cannot afford for TDM1, at least giving adjuvant trastuzumab is a good idea, rather than not doing any treatment. That is what we generally follow it.
Thank you, sir. Moving on to the next case.
Can I just say one thing that, although you said that it's a short follow-up of the Catherine trial, given the magnitude of the difference, that difference is unlikely to vanish and disappear. So, it seems that, as and when the trial is updated, I mean, from whatever I have known about oncology, that difference is unlikely to disappear. I just wanted to, with your permission, ask my colleagues from the US and also Dr. Shekhar Patil. The other day, we had another panel discussion where a patient with a large tumor after neoadjuvant HER2 targeted therapy and chemotherapy, everything disappeared except a nodal micrometastasis in one node. Now, is that PCR or is that no PCR? And what would you do? Would you give TDM1 or would you continue with the usual treatment?
So in Catherine, they did show this analysis looking at the amount of residual disease, and the benefit was seen irrespective of even in the teeny tiny, they looked at T1A tumors, for example, that are residual. So I've taken any amount of residual disease to be indicative of need for TDM1, given the benefit was seen there. And while they did have a tremendous benefit, there's still a few cells left. We even count ITCs as being residual disease and post-pre-op therapy still. So, not a PCR. So we do count any amount of disease as, at least for indication for TDM1.
And the other point too is those patients, there were several, I forget the number exactly now, 7 years so, that actually had HER2 negative biomarkers at surgery, and those patients still seem to benefit. So even if they, you biopsy and you do biomarkers and they're negative, I would still continue TDM1.
Yeah. Yeah. Thank you, sir.
Moving on to the next
Patricia, I
case.
think Dr. Tolaney has to, she has a meeting right now and she has to get off. So is that
Okay.
right, Dr. Tolaney?
I'm so sorry to have to step off, but thank you. This has been a wonderful discussion. I certainly learned a lot as well. So thank you very much for having me.
Thank you so much for being there, Dr. Tolaney.
Thank you.
You can go on with the case presentation.
My second case would be a 60-year-old postmenopausal woman, again with no known comorbidities, evaluated for left breast lump. Bilateral mammogram was suggestive of a BIRATS 4C with the clinical staging of T2, N1, M0. True-cut biopsy was suggestive of invasive ductal carcinoma with the ER of 6, PR of 6, and HER2 3+ with a Ki67 of 25%. PET-CT was suggestive of an increase in FDG uptake in the left breast with left axillary nodal uptake as well, with no distant metastasis.
Can I ask a question? Why doing the PET-CTs? Because though, in the US, we have a hard time getting PET-CTs for these kind of patients. So in a resource limited area, why are you able to do these?
Hospitals that are where they practice are not really resource limited. Very affluent patients will visit many of these private hospitals, and I completely agree with you. I was going to ask the same question. In one of the previous cases, it was a T1 N0, and why would one do a PET-CT scan?
Right, just for the benefit of the younger oncologists on here is definitely in the last one would not have done a PET-CT, and probably not in this one either, but just another point.
In India, can I come in, sir? In our hospitals where the cost of the PET-CT scan or getting an appointment for the PET-CT scan is very, very easy. If a patient comes today morning to get a CT scan, sometimes it may be difficult because PET is freely available and cost also is more or less similar to that of a CT scan. At that time, is it wrong to use a PET scan? Is it wrong to use a PET scan if facilities are available and if the cost remains the same? That is what I would like to ask.
Dr. Patil, what I would say is that, if the pretest probability of distant metastases are low, as they are actually in these early stage breast cancers, even a positive PET scan is much likelier to be a false positive. And I have seen innumerable cases where, the treatment got distracted because of an incidental finding on the PET scan, and then everybody started chasing that PET scan finding. I've seen so many cases. And, there is a reason why all international guidelines do not recommend routine systemic scanning of patients with these early stage tumors. And that is because the pretest probability is so low that any finding on a scan is likely to be a false positive. So, from my own experience, I have seen, patients coming with a 0.4 centimeters prevascular lymph node somewhere in the chest, and then everybody is scratching their heads as to what to do about it.
I agree, sir.
That, in my opinion, is a potential harm of overscanning, but maybe Dr. Swain can also opine.
No, I agree 100%. I think in this patient you have up there right now with 5 positive nodes, I would be less reluctant to get a PET scan. So I think it's worthwhile. We probably would stage someone that has that many positive nodes. Okay, now that we've distracted you from the point, you can go on.
Yeah, so this patient, she underwent an upfront surgery as she landed up in a surgical oncology department with an MRM and axillary lymph node dissection. The post-op histopathology examination revealed a tumor size of 2.1 into 3 into 1.2 centimeters with 5 out of 19 lymph nodes positive, ER of 8+, PR of 6+, and HER2 3+ with a Ki67 of 30%. This patient went on to receive adjuvant 6 cycles of TCH followed by radiation therapy and maintenance trastuzumab for a total of 1 year. She is currently on letrozole. So my question here would be directed to Dr. Sudeep Gupta, sir. So what would be the role of pertuzumab in node positive, a hormone receptor positive case in the adjuvant setting? Would you prefer giving pertuzumab along with trastuzumab in the adjuvant setting?
Yes, if the patient has 5 lymph nodes positive, if pertuzumab is accessible, then yes, I think there is reasonable benefit with adjuvant pertuzumab, and unlike my opinion in the neoadjuvant setting here, I will offer it, provided, of course, it is accessible.
I would like to direct the same question to Dr. Sandra Swain as well.
I totally agree. And I think we saw the data, it's about a 5% or so benefit in those patients that had positive nodes. So, and she had a lot of positive nodes, you know, greater than 4. So I definitely would give it to her if available.
Okay. My next question would be to Dr. Sandra Swain again. What would be the role of neratinib after completion of adjuvant trastuzumab? Now, we don't have availability of neratinib in India, so our knowledge is very limited. Would you please share your experience?
Sure. So we always discuss it with patients, especially this kind of patient that had very high risk with many positive nodes. And as you know, the ExteNet study did show a benefit of neratinib, especially in those patients who had ER positive tumors versus ER negative, which was kind of interesting. So she did not have an ER positive tumor, but because she had such a high risk overall, we would discuss it. It's not an easy drug at all. The diarrhea is very significant and close to 100% of patients, and it's not pleasant for the patient. So a lot of them will not even continue it, but I think it's we would discuss it.
Yeah, I think, Pratyusha, you're done?
There's the few more questions, sir. The next, yeah. So the first one would be directed to Dr. Shekhar Patil, sir. So in this particular case, would you do an ovarian suppression because she's triple positive? What is your opinion on ovarian suppression in a triple positive patient?
Generally, we don't do it, and we continue with only after the chemotherapy, continue with the trastuzumab and continue with the hormone therapy, whichever she is eligible. She is a premenopausal lady.
Yeah.
But how else would you use letrozole if she's premenopausal?
Right.
I mean, you do need the ovarian suppression if you do choose to treat with letrozole. I mean, the alternative would be to use tamoxifen here.
Correct. Tamoxifen.
I mean, I'm asking Dr. Pratyusha because here I think you chose to treat her with letrozole, if I'm not wrong.
Yes, sir, because she's a postmenopausal woman. If she, in case she was a premenopausal woman, would you do ovarian suppression?
Okay. So you are asking if she was premenopausal, would you use ovarian suppression? Okay. Sorry, I interrupted you.
Yeah, it is possible because she is a very high risk. We don't know which she is driven by the hormone receptor or by the HER2 driven disease. So premenopausal women, I think with so much of node positivity, I would have a ovarian suppression with change to letrozole and continue with the trastuzumab. That is what is another thing.
I would agree with that. I mean, her risk is very high, so I'd give her the benefit of the doubt and give her a maximal HER2 targeted therapy and maximal endocrine therapy.
This question is directed to Dr. Sandra Swain. What is the role of adjuvant TDXT now that it is, the Destiny Breast 05 is an ongoing trial? What is your opinion on adjuvant TDXT?
Well, I think obviously we don't have results and the trial hasn't even completed accrual. And you saw that in the lecture that it's post neoadjuvant and post surgery, comparing it to TDM1. My prediction is that it will be much better than TDM1 since it was much better. I mean, remarkably better in the metastatic setting. So if that's the case, then we certainly will be using TDXD in those patients who don't have a path CR. Also, as was shown, it's being tested in the neoadjuvant setting. So it may even come earlier and hopefully it will be as good as it is in the metastatic setting and cure these patients. And we won't have this 25% risk of recurrence in the future.
Thank you, everybody. Thank you so much.
Can I just add one point about the use of TDXT in the neoadjuvant or adjuvant setting? So I agree with Dr. Swain that, from whatever we know of this drug, it is possibly likely to be more effective than the current treatments. I just want to add that the threshold of what would be acceptable toxicity in terms of ILD would be much lower in the curative setting compared with patients with metastatic disease. So, just in case it turns out that a substantial minority of patients do turn out to have significant lung disease, I think that might also be considered when we eventually appraise this drug.
I think the other point too is we may not need to give TDXD for a year. I mean, it's possible you give it for a few cycles and then you change to trastuzumab. That would be another scenario, though that hasn't been tested yet. But I think that's what a lot of people think from even the Destiny 11 study that's looking at first-line metastatic. Instead of continuing it, changing it to a more tolerable HER2 targeted therapy.
Yes.
Thank you, Dr. Pratyusha. Thank you, all the experts. And I now would like to ask Dr. Santosh to give the concluding remarks and summarize the webinar. Thank you so much.
A wonderful session in this first of the series of ASCO endorsed CPOEM webinars. We would like to thank the speakers, Dr. Sara Tolaney and Dr. Sudeep Gupta, and the chairperson, Dr. Sandra Swain and Dr. Shekhar Patel, for their very active participation and the great insights. We also want to thank ASCO, Dr. Julie Gralo, Ms. Sara Backman, and Ms. Jessica Williams. And thank our colleagues, Dr. Swaroop and Dr. Pratyusha, for their presentations. And the sponsors, Zydus, Roche, Viatris, and Intus. All participants will receive a certificate of attendance after the webinar. And I would like to request them to fill the feedback form that will be sent to them via ASCO, via email, and that we need to share with ASCO. And our next webinar is with Dr. Jason Wested from the MD Anderson Cancer Center on relapsed DLBCL on 21st of July. And do save the dates for this interesting meeting. Thank you. Thank you, one and all.
And thank you all on behalf of an ASCO. I thought it was really great. And Dr. Gupta, thank you so much for presenting all of your data too. It makes me think quite a bit. And I think that's important that we have more equity and access to these drugs. So thank you.
Thank
you. Thank you very much, Dr. Swain. Take care. Bye-bye.
Bye.
Right.